All right, thank you everyone. As always, Outback responders would like to acknowledge the Aranda people, the custodians of the land on which we meet. We want to acknowledge the strength and resilience of the Aranda people and pay our respects to elders past, present and emerging. Thank you so much for coming. I'm really excited about today, and Carol has brought some placentas for us to play with after as well. This will be an awesome refresher. Like I said, Curly's not with me today, so I just ask that any questions you have, you just give me a second to get to you so that you can speak into the phone, so that people that are watching at home afterwards don't miss out on what's being said. But I'll hand over to Carol, who's going to take us through being ready for if one of our patients become two. So thank you. Thanks.
Okay, so most of you probably know me from RFDS, but you also know that I actually work in the maternity ward as well. So that's why Amy's asked me to do this today. Okay, I'm going to go on to the objectives. So I'm going to do pregnancy. So I've tried to use it with ISPAR, which is most of our things. Antenatal complications, is it really labour, stages of birthing, and then the complications you're going to get. Okay. Okay, identification. So look, I've even managed to find photos of our so identify ourselves, identify the patient. As you can see there, it's going to be difficult to identify those patients. Which one's the one that has actually called you? Not being judgmental, but in our area we have a lot of Indigenous ones. Currently on the books in maternity we have 4 14-year-olds, 3 13 and a 12-year-old that is due to have a baby. So they're not all. And last 2 months ago I birthed a 51-year-old. So there is a big range of people. Okay, next one. Cultural considerations. Indigenous women, often younger than non-Indigenous women having babies. I have more babies than non-Indigenous women. Often have preterms, 140 to 80 of the non-Indigenous. They often have low birth weight babies. They birth by grandmother's law. A lucra, which you may all know about, is out in Percy Court. It's women's business only. They run off grandmother's law, where the grandmother passes down the knowledge to the younger people. Often we have grandmothers come into birth with the patients, but these days it's getting more and more common having the partners there. That's why you'll find this Larapinta Clinic and Saturday Clinic are now out in the communities, and they will allow males come into the antenatal checkups. So that's why those clinics have been put out there, because there is no males allowed on the Aluka things. Sit down. Our clinics often have our hostels full of sit down pregnancy. The idea is they're brought in at 38 weeks to birth. So they sit down. Often they have these family responsibilities for funerals, that they manage to get their own way back out to the communities. Last week we had a 42-week of birth at Yundamu because she decided the football was more important than staying for sit down. Shame. Often our women, I know it's for the guys here, don't like talking to guys about their pregnancy, so you'll find they respond better to the female responders. And jealousy is a big thing in there. I think they like to have their partners in because they're afraid they're going to go off and be with other women, so they're very protective of having their partners in. And language, like our sugars and our shortness of winds. Placenta's classed as a baby bag, ultrasounds are baby pictures, and contractions are baby pains. So that's the better way to talk to them. If you're talking about contractions, they won't know what we're doing. Okay, so we've got a situation where they're pregnant with abdo pain. Question is, does the pregnancy change our response to that abdo pain and our management? So, background, what do we want to know? Is this the first baby, second baby? If it's the first baby, they often don't know what's happening and they will take a lot longer to deliver. If it's the second baby, their body knows what they're doing and they'll often go a lot quicker. Obviously, fifth baby, go very quick. Gestation and number of babies, if known. A lot of our women don't get antenatal care, so you don't really know how pregnant they are. And whether there's twins or triplets in there, not often. Hopefully those ones we actually do know about. Often they just, because of shame in the community also, 15-year-olds, they hide the fact that they're pregnant, so they often will have babies younger and hide the fact, so they'll come into the clinic with no antenatal care, so you're not too sure what they're doing. Description of pains, where they are, the location of it, whether it's constant and when they start. Is there baby movements? Previous delivery details. Spontaneous vaginal birth, at least then, if they've had a spontaneous vaginal birth, we know it can birth. Okay, that's the biggest, the biggest rule. If they've had a Caesar, we want to know why they've had that Caesar. Maybe they can't birth, maybe they've got pelvic disproportion, or whether it's just been fetal distress that it's had. But we know if they've had a previous spontaneous birth, we know we can pass the baby, which is good. Any PV discharge, if they've broken their waters, when to break, what it looked like, if it's green, yellow, or clear. Any medications and allergies. Medication is a big thing. Compliance is a big thing in Alice. They might have medications, but they're not taking them. So often our diabetes or our blood pressure medications aren't taken. Medical history, diabetes, rheumatic heart disease. Pregnancy puts a lot of strain on the heart, so often our rheumatic hearts. Diabetes is a big thing in our normal women, let alone once they get pregnant, okay? And antenatal care, if they have and where they've had it. Most antenatal care, if they've had anything, comes into the hospital. So actually you could actually ring out the hospital and say, has this person had it, and get some sort of history on it if you really were desperate. Okay. Assessment, routine OBS, temp, blood pressure, pain, describe the pain location, where it is, whether it's constant or intermittent. Discuss the colour of the PV loss, if there is any, and how pregnant. Your assessment and response will vary depending on that history, okay? So, physiological changes. We all know about the emotional ones. They're all emotional. They change. Endocrine, they produce a lot of different hormones. That's why we get the emotional changes. Musculoskeletal, the hormone changes in their bodies, they produce a hormone called relaxin. It relaxes the pelvis to open up the pelvis, but it relaxes all your other joints. So they're more likely to roll their ankles because the tendons are relaxed. And also the centre of gravity has changed. Respiratory, they have an increased tidal volume. They often have to breathe more because they've got this pressure up here. They can't expand their lungs as much. Metabolic, lots of changes because they promote water retention, increase weight. Mainly our problems are the cardiac output. They have 30% more increase in blood volume for a pregnant woman, which increases your heart rate, and which is also extra blood flow to the uterus, and your vascular resistance. So for blood pressure in a pregnant woman for the first 20 weeks, you might have it at about 90 systolic, okay? So they will have a lower blood pressure. By about 20 weeks, they'll start to get back to their normal blood pressure. Okay. Okay, but what about me? We also have a second patient on board, right? Depending on the gestation. Remember the fetal heart. It's done at the anterior arm, so basically up here is where you get your fetal heart. And abdo-pal will help you if you can't work out. If they haven't had any antenatal care and we don't know how pregnant they are, abdo-pal may help you, and it'll also help you if it's going to birth and you need to know where the head is. Okay, so I'll go through your abdo-palps roughly just so that you can have an idea. Okay, so if you don't know how pregnant the lady is, the idea is the baby is behind the symphysis pubis, it's about 12 weeks. So if you can't feel anything, 12 weeks is behind there. You won't get a fetal heart, so don't even try. We look at the umbi as finger underneath the umbi, we're at 20 weeks, finger above, we're about 24. So if you can feel the fundus up 24 and keep going about fingers, 2 weeks each finger kind of thing, it's the quickest way to say they're roughly, if there is IUGR, you're not going to be able to assess it. If they're quite large, it's going to change your management as well. But that's the quickest way without a tape measure. Normally we tape measure from the symphysis pubis to the top of the fundus and say 30 weeks, they're 30 centimetres, they're 30 weeks is really the idea. But this is the quickest way without a tape measure to try and get some sort of textbook thing. Abdopalp. Abdopalp, it is a skill, okay? very, but for your situation, the idea is to try and work out where the head is, because if you're going to birth, you want to know it's the head rather than the bottom coming out first, okay? You can feel the back. You can actually ask the mum where they're getting kicked. Often that will give you an idea. But the head, its head on a baby is ballotable, what we call, so it can move, where a bum can't. So that gives you a bit of an idea. If you can feel the part up here and you can shake it round, the head's up the top. Okay. Most times the head should be in behind the pubis there if you're going to birth. That'd be nice. So no great skill in that. Obviously it comes with practice and midwives do it all the time, but I'm just trying to give you some idea of how to work out where the head's down. Okay. First trimester complications. Implantation, bleed, light spotting, quite normal. It happens in a fair few cases. It's trying to implant into the uterus and they just have a little bit of bleed. So it's light spotting. Miscarriage in 10 to 20% in the first trimester. They'll get some moderate heavy bleeding and some back pain. And that is a miscarriage. There is nothing you can do about it. I know it sounds terrible, but there is nothing. Hyperemesis. Don't get confused with morning sickness. Morning sickness is a bit nausea. Hyperemesis is constant vomiting. They change their electrolytes. They get the ketones. They need IV therapy basically. So it should relieve by 20 weeks. Hyperemesis, unless they're a great cannabis smoker. They'll have hyperemesis all the way through their pregnancy. So there is an indication. We do know that without even telling us that they'll constantly be up on the thing, vomiting, half-hour medication won't work, and they'll be in the shower all the time. We know that they're high carb. Ectopic pregnancy, 1 to 2% of cases. Risk factors, if they've had a big history of PID, scarring on the uterus, the ovary can't work out where to implant, so they'll often have a ectopic. IVF have them if they've got IUDs in, and they're mainly between the 4th and the 12th weeks as an indication. But if they've got a positive pregnancy test, got abdopain, cramps, and low blood pressures, you've got to rule out an ectopic. Okay. Dizziness, weakness, nausea and vomiting, sharp pains, abdo pains that radiate to the neck, all an indication of an ectopic pregnancy, and it's quite an emergency if it's because that can rupture and then they'll bleed internally. Okay. Second trimester, bleeding, minor cervical irritation. We often get bleeding from they've had sex. This seems to be the biggest thing. They've had a bit of sex, it's hit the cervix and they've got a bit of irritation. Miscarriage in this stage, they'll often have very large clots and some abdo pain. This thing called cervical shock. They can abort the baby and the products will stay in the uterus and it gives a vasovagal reaction to the uterus and they go into a bit of cervical shock from that. So that is a bit of an emergency. We just need to evacuate the products. Placental issues is the placental previa. You're going to get a bleeding from that because of the placenta is in front of the baby. So if that starts to tear away, the baby can't come out through a placental previa because obviously the placenta is blocking it. They're often a Caesar, but we have people walking around. They have a low-lying placenta that could be just off, and once they grow the baby, it does move out of the way, but most times the placenta previa will block the entrance, so they will actually bleed. Abdo pain, often abdo pains at this time. UTIs will give them false pregnancy symptoms, STIs, thrush. So all those ones you bring into the maternity that go, oh, they've got early labour, they could often a UTI or an STI. We just treat that and send them home. Preterm labour, the only thing is there, if you've ruptured membranes, preterm labour is cord prolapse. So I'll just go through. So cord prolapse is when the cord comes out before the baby. It is a bit of a medical emergency because the head will then go onto that cord and the baby will get hypoxia from it, squashing the cord instead of as it comes out the cervix. So it's no longer getting the blood supply to the baby and the baby will get hypoxia. And having the cord out in the cold actually gives it some spasms, so therefore it won't produce the blood supply to the baby as well. So the risk factors preterm, lots of fluid. If the baby's floating around, obviously lots of fluid, fluid will rush out and the cord will come with it. Multiple pregnancies, high presenting part, if the head's not right down there, the cord can easily come out. And we'll go into the next stage. So what we want you to do, the assessment, cord visibly in the vaginal, the fetal heart rate is decreasing, and obviously you have to have ruptured membranes. So what we need you to do is do a digital pressure. So get your fingers, push the baby's head back up, and you've got to hold it back up till you get to the hospital, okay? You need to get that baby's head off the cord so the blood supply can get back to the baby. Okay.
You can just do that with one finger?
Yeah, you can do one finger, two fingers, depends on how big the baby is when you look. Yeah. So you're going to have to just get it up. But we put the, try and get the cord either back in just in the vagina, not right up in the uterus, just to keep it warm and not exposed to the air, or wrap it in a towel so that it's not exposed, that stops the spasms. So basically, the other thing is you can feel the bladder. I don't know how often you would do this. Put a catheter in, pump in 500 mils of water. That pushes the bladder. It does the job of pushing the baby back up. Okay. Tycholysis, which you guys don't have apparently. So basically, you can see that position. Anything to take that baby off the cervix. So get them on their hands and knees, the bottom up. Push that baby back in. So we'll go into the next one. Now, this is your ethical dilemma. If you've got a preterm baby and it births between 30 to 23 weeks out of hospital, it's probably not going to survive. So this is the recommendations that we've got. In hospital with a high intensive care, nurseries, 23-week babies will probably not survive as well. So don't think you're doing the wrong things, okay? So that life-sustaining interventions at 23 weeks, unless you've got a big high intensive care hospital and someone there to intubate them straight away, they probably will not survive, okay? So this comes down to the ethics. If you don't know the pregnancy, or they know that they're 23 weeks, if you birth that baby, it's probably not worth your while to resuscitate that baby. It does come down to a ethical dilemma here, and they'll ask, did that baby take a breath? I've got some neonatal nurses up the back and they probably say, yeah, no, don't. The baby didn't take a breath, okay? So that's, you'll know in the hospital we say 20 weeks up to maternity. So this is like a gestation kind of thing. 25 weeks, we're pushing it, but if it's in the hospital, we could probably do something about it, and they'd still have to go to Adelaide. But it comes down to an ethical dilemma for you guys. Keep going. Third trimester complications, diabetes. Yeah, pretty much all our patients have diabetes. They get big babies. They have lots of fluid around them. The biggest concern is if you're birthing a diabetic baby is the sugar on the baby. The baby has used lots and lots of sugar in the thing, and they'll drop their sugar really quickly. So within half an hour of birth, we need to know their sugar, and that baby often comes out as a 1 or a 2, and we have to cannulate it all. The best thing you can do to get the sugars up, put them on the breast and let that baby breastfeed. That's where you're going to get the sugars, okay? Preterm labour, placental abruption is when the placenta starts to tear away early with bleeding. Infections again, just excessive vasomotor. Sometimes we get ladies come in saying they're in preterm labour and the baby's just tossing and turning. They're not actually in labour, they're just feeling the baby. Preterm rupture, check for cord prolapse, note colour and time, are the contractions present. Even if they rupture their membranes and they haven't gone into labour, they need antibiotics within 18 hours because that sac is now open and exposed to the environment. They may need steroids there to start developing the baby's lungs, so transport to the maternity unit. Trauma, most trauma cases start off in ED, maternity midwives, not for CPR, like they're not out there to save bleeding or chest pains or stuff like that. They won't be able to do it. There's no cardiac monitoring in maternity. So it started off in ED and then they'll come to maternity or they'll get an assessment by maternity. We'll send it down. We have to do cardiac monitoring of that baby for, I think it's 8 hours. So once the mum's okay, there is a rhesus negative patients, that negative blood group ones, we need to give the mum some anti-D to produce. When the baby's positive and mum's negative, the mum will fight having that baby. So if the blood cells of the baby have crossed into mum will reject the baby. So we need to give it some what they call anti-D to stop that rejection if it's crossed over. Preeclampsia. Okay, preeclampsia is a multi-system disorder unique to pregnancy and usually over 20 weeks. Most commonly around the 32-week mark. It involves the renal system. It has protein, creatinine raises and no urine output. Liver functions are elevated. You have severe right upper quadrant and epigastric pain is a symptom. Neurologic headaches, visual disturbance, high blood pressure. If it goes to convulsions, it becomes eclamptic, and we have thrombocytopenia. Edema of the face, hands and feet is actually they're starting to rule that out as a sign now, but it is an indication. We'll go on to the next one on how to treat. Risk factors, lots of chronic hypertension, previous history. Teenagers are likely to get more preeclamptic than older women. They're not too sure exactly why you get it, but they're thinking maybe it's to do with the placenta. Mild to moderate, 140 on 90 becomes a preeclamptic lady in pregnancy. Okay, so that's a moderate thing, but it's 140 on 90 over multiple readings, okay, not 140 on 90 every 5 minutes, okay, they've got to give it time. They'll have protein in the urine and they'll have those symptoms as well. Severe, 170 on 110 on 2 occasions, protein and symptomatic again. Now, management. I've learned a couple of things about St John's at the moment. Airway, high flow oxygen, IV access, okay? Limit fluids because we've got high blood pressure. Prevent the seizure. Now, Amy has told me you guys have nothing really except an ICP has magnesium sulfate, okay? We don't use Midaz for seizures for preeclampsia. Magnesium sulfate. It's a neuroprotection of the mum and the baby as well. And it will, once they're on it, we put it on it for 24 hours. But we monitor all the vital signs, neurological status, watch their fluid output, urine output, they get a catheter, and then the fetal condition. Transport ASAP, that baby needs to be probably birthed within the next 24 to 48 hours. We may actually keep it monitored and give them some steroids to develop the baby depending on the thing, but we'll probably do an emergency seizure on those ones within 48 hours. Okay, I'm so ready to have this baby. So let's go on to the next one. Is it really labour pains? True labour pains comes regularly, gets closer together, lasts 30 to 70 seconds, pain in the back and the pelvis. 5-1-1 rule, last 5 contractions in 1 minute, lasting an hour. So that's an easier way to say 5 contractions in 1, lasting an hour is a good urine full lone labour. They have a show or rupture, they often have nausea and vomiting, pressure, tightenings are felt at the top of the abdomen. They will feel the pains down here, but if you want to see where they're having contractions, you feel the top of the fundus. It tightens and relaxed. tightens, relax. So once it tightens, then you count how long it's tightened for. 45 to a minute is a good contraction. Okay. False labour. Pains are irregular. They last 10 to 20 seconds. They often are related to the baby movement, don't get closer together, and they're often just felt in the front rather than the back, and often relieved by movement. Okay, stages of labour. First stage is the dilation. Second stage is pushing the baby out. Third stage is taking out the placenta, and the fourth stage is monitoring the lady afterwards. We'll go through that. Okay. First stage, latent stage, is onset of labour to 3 sets. It's softening the cervix and thinning the cervix. This can last for weeks. You can walk around with 2 to 3 centimetres dilated for a week before you actually go into labour. Okay, it's your body. So it's not too painful, but some people it is painful for. They'll come in. Relieved by shower heat, paracetamol. Active 4 to 7 centimetres. Contractions are 3 to 4, lasting 40 to 45 seconds. Get leg cramps. Membranes might rupture at this stage, and increase in the back pain. Transitional stage. You'll know a lady's in transitional stage. They're 8 to 10 centimetres. They will swear at you. You do not know what want. They might. I'll put a cold compress on. I don't want that. Oh, you want drink? No, I don't want that. Yeah. And that's when the husbands sit there going, oh, they're not normally like this. They'll swear, I don't know what I want. I can't do this. They're in a transitional, so they're 8 to 10 centimetres. So that's the best indication to tell. Okay. So what these uterine contraction? Yeah. No. Go. Yeah. Are doing. So we're opening that cervix. You can see it's opening, and the baby is rotating at the side. So you can see how thick that cervix is. 5 centimetres. It's getting thicker, and the baby is rotating at the same time. Okay, we want the baby to come out with its head like this. Okay, so while it's opening, it's also rotating the baby. In America, they've got a different way. This is easier for you to see where you're up to. So once you get to a bagel, then you're 10 centimetres, okay? I thought it was a bit harsh because the women don't feel like we are eating, but